Leadership in Mental Health. Sir has an MBA from IIM Ahmedabad and a Ph.D. in Economics and Finance from the University of Pennsylvania. His current work is principally focused on the design of national and regional health systems. He is also a senior research fellow at the Center for Information Technology and Public Policy at IIIT Bangalore, a board member at Navi Technologies and Swasth Digital Health Foundation, and a health advisor at Livestock India. He serves as a commissioner on the Lancet Commission on Reimagining India's Health System as well. Sir has also written multiple research papers published in reputed journals, and today he will be speaking on the topic Pathways to Well-being, the True Measure of Prosperity in Chhattisgarh. Sir, the stage is all yours.
Thank you very much for inviting me here, Director IIM Raipur. I want to thank the Director of the Institute for asking me to be here and to talk to all of you. It's a wonderful program. I must say you will be a little disappointed with my conversation. It's much more technical and much more focused on specific issues. You learned real wisdom of life from the previous speaker. Mine is more, I would say, broader, more abstract, and speaking a lot more from my research and from my work in the area of healthcare and health systems design. So I have a few slides that I want to share with you, but I'm going to try to make sure that we have enough time for Q&A because it's hard for me to read the room. I did something similar at IIM Calcutta and it was received reasonably well, but I want to see how I can change the format a little bit here. So, one of the issues, and Sir spoke a little bit about the whole meaning of prosperity and how we can think about prosperity for the state of Chhattisgarh. One of the issues that I worry about personally is that as we think about the growth of the economy and we think about people being able to find their own destiny and to go where is appropriate for them, if, for example, stunting in India, right, it's currently severe stunting, which is where the child is what we call severe acute malnutrition. It is over 10%. Right? And in the last 5 years, pre-COVID, this number has gone up. I live in Bangalore. Bangalore, the number 2015-16 was 15%. It has gone, which was 8%. It has gone to 12% in 1920. Problem with severe acute malnutrition is it not only has an impact on mortality probabilities, it leads to cognitive decline. There is, this is a bit controversial area of work, but people argue 20 IQ points drop in the child if they are going through severe acute malnutrition. So in some ways, if we want to see the theme of your Gyan discussion is about prosperity of Chhattisgarh, health becomes a very key component of this issue. And one more perspective I want to share with you before I go into the heart of what I'm saying. One of the areas in which I work is what we call complex adaptive systems. You might or might not have heard of it. It's a tool that is useful when you are modeling systems that have too many dimensions. Right? If you are working on one area or two areas, it's easy to draw a bar chart and a graph and say something about it. But what if you have problems in which there is a time dimension, there is a equality dimension, there is an economic dimension, there is a trade-off between today and tomorrow. These things are hard to capture in your mind and to try and keep everything organized. Right? Complex adaptive systems is a tool that allows you to build these kind of scenarios in which you think about the world 5 years from now, 10 years from now, 100 years from now, and to try to think about what the world will look like with interventions today. What is interesting, again speaking to the theme of some of the issues I'm going to talk about, is that if we imagine the world 5 years from now, or even 10 years from now, curative systems are very important. What hospitals you have, what primary care you have, what tertiary care you have is very important. As you fast forward 25 years, these things become much less important. And what matters much more is what we would call social determinants of health or One Health, which are much broader engagements of health. And I will, it sounds like a bit of an abstract idea. I want to talk a little bit more about, for a state like Chhattisgarh, what does it mean as it imagines its future, as it thinks about planning for where it goes. One of the issues, though, that when I talk about health to people, and often I get this from young academics or students, is that what is the need for intervention? Why do we even want to intervene in health? Right? Because you don't get interventions in the clothes market or in the microchip market. People don't say we need to create a whole department for clothes. Right? But in health, everybody is very interested in getting involved with it. One of the questions, of course, often you get the response that, well, health impoverishes people. When people get sick, they have to pay money and there is poverty. I would respond to that by saying, well, growth will take care of that. Why do I need to worry about health itself as an issue? And I was told that, I shouldn't make it too technical, but since, I do have a Ph.D. and I'm getting another one, I do want to share some of that, kind of stuff with you. One of the challenges that we feel, in any market system, and I'm told you've studied macroeconomics already, so you will have a little bit of a sense of this. There is one idea which is that of a competitive equilibrium. What competitive equilibrium means is supply equals demand, right? And typically there is a price at which that equalization happens. That is a very different idea from efficiency. Efficiency, and it's named after an Italian economist called Vilfredo Pareto, and therefore referred also to as Pareto optimality, is optimality in which there is no waste. That is, all the resources you have, the classic example people give is, there is no money lying on the side of the road that anybody can pick up and do something. During demonetization it happened, but that general money was not very valuable money. Right? But that's a notion of efficiency. And then when people say, okay, well, you've got, competitiveness, you have a price, you can argue efficiency, there is a third idea called social optimality. You may get a good equilibrium, but some people, as Sir spoke, are very rich, and some people are, or many, are not very rich at all. The canonical argument is, well, that's not a new problem, it's a problem we have addressed before. The way to address it is to tax the rich, redistribute the wealth to the poor, and let the competitive market economy take over again. But this is nothing new. This is something we know across the board, and in fact, this is one of the core roles of the government. It doesn't give us an argument as to why we need to intervene in healthcare. And unless we are clear about why we need to intervene in healthcare, we don't know what intervention will make sense. Right? So, it's a kind of, it's not a new idea, but it's something to be conscious about. I won't talk about public goods. Healthcare, we might argue is a public good, but if, for example, I got a heart attack and I needed to be taken care of, it is very much a good that has a price, that has limited supply. If I got served by a hospital, right, it meant somebody else didn't get served by the hospital. If the hospital charged me 5 lakh rupees for that treatment, it meant at that particular price, they believe demand will equal supply. They don't charge 25 lakh rupees, nobody will show up. If you make it totally free, everybody will show up. Right? So clearly it has the character of a public, even if it's delivered by the public sector. Just because you're not paying doesn't mean somebody is not paying, or that there is no cost associated with it. One could argue, therefore, if it's a private good, it has the same logic as clothes, automobiles, toothpaste. Why do we need any intervention? What is the reason why anybody should get involved or care about healthcare? There are some aspects of healthcare which are quite important, which we call market failures. Right? And a lot of my work is in trying to understand these failures and to understand what are the sources of these failures and then what can we do about them. And let me talk a little bit about that. We know that you have competitive markets, there is a price. The concern is that Pareto optimality is not coming. And why this is an important issue? Because a lot of underlying thinking about markets, when people talk about markets or when you study competition, perfect competition, imperfect competition, etc., our underlying belief is that markets will pick it up. If demand is not there, people will not make the goods. If supply is not there, the demand will gradually peter out. Even today, as you are seeing inflation, right? I used to be on the Reserve Bank board. One of the roles of Reserve Bank is monetary policy. And what do we worry about? If there is a lot of inflation, you raise interest rates to dampen demand, to say that we don't have enough. In fact, I'll tell you a very nice story. Eddie George was the governor of the Bank of England, and me and my boss happened to visit him one day. And he's one of the, I don't know if you've heard of Eddie George. Eddie George is one of those colorful central bank governors. So he told us that for a long time, Bank of England used to set interest rates looking at wind patterns. So they had a room in which there was a wind vane, and that said, if the wind is blowing in this direction, easy policy. If the wind is blowing in that direction, tight policy. We thought this sounds like a strange story. What is the logic of, hawa ka rukh dekh ke, you are making monetary policy? Well, it turns out that there is a logic to it. London is on the Thames. It's not on the sea. And sail-powered, wind-powered ships could come in to the bay, to the docks, only with a certain wind. If you got a lot of ships showing up, you needed to relax money supply, because otherwise you would have inflation. Right? If the wind was not favorable, goods couldn't come. You needed to have tight money, because there are no goods. If you pushed money in, it would artificially increase the prices of goods that were not actually there. So it's an interesting thing about what people would do to worry about in a market how people are operating. Why do I believe that there is insufficient evidence that there is a efficient market or Pareto optimal market? From common behavior, you will have a sense that there is excess demand for hospital care. Right? You go to any hospital in the country, any government hospital in particular in the country, in the state, you will see it's full of people. If you have time, have a chat with them. Right? So one of the things I do, I go to AIMS, I went to CMC Vellore, they asked me to spend 3 days with them to understand what's going on. You talk to the people, most people, I don't have a precise number, but I would argue somewhere near 90% of the people are in the wrong place. They don't need the services in this hospital. They should have been taken care of somewhere else. A friend of mine was the director of JIPMER. It's a leading medical college in Pondicherry. He had recently joined as director, so I went to visit with him to see what is he doing and how is he happy about it. He had come from the US to take on this job. So I was curious to see how did he find this transition. He was not a happy camper. He took me for a tour on his maternity wards. He said, Nachiket, I am a Pondicherry. JIPMER is what they call not just tertiary, quaternary care. It's a hospital that provides very advanced care for very advanced diseases. Right? You go to the maternity ward, it's full of women doing routine deliveries. He says, I should have been dealing with families and children that were 700 grams, 1200 grams. On complex respirators, trying to figure out how to make them survive, really complicated cases. I'm dealing with routine care. You will see in a number of cases massive demand. In fact, price elasticity is such that if you have a heart attack or if you have a situation that is debilitating, you will not negotiate price. I had a friend of mine, he was a criminal lawyer. He told me that the best time to negotiate price for my fees, for his fees, is when that one call from the jail happens. Because at that time, you're not going to negotiate. All you're saying is, get me out of jail as quickly as possible. Hospital care has that characteristic. On the other hand, if you see primary care in an open market, where everybody is paying for services from their pocket, no government is involved, nobody else is there, you will not see much demand for primary care. There is in fact very high price elasticity. I shared with your academic colleagues earlier today, very nice paper by Dupa and Miguel, in which they examine and they look at many aspects, but one particular thing has become very famous, is the work that they did on mosquito nets in Kenya. Kenya continues to have a high burden of malaria. You would imagine in such a place, mosquito nets will be selling like hotcakes, right? Because most other diseases like hypertension, for example, you don't see the evidence of pain. Kuch andar ho raha hai. A friend of mine is a liver transplant surgeon. He says, I wish the liver was part of the face somehow. Because if there is a small pimple, you'll work on it for hours. The liver is completely getting destroyed, but you don't see it. So you don't do anything about it. The mosquito is like the pimple, it bites you. Despite that, unless the price of a $7 mosquito net falls below 50 cents, there's no demand for the mosquito. It rises only at very low prices or near zero prices. Again, another example of elasticity, very high price elasticity. This is just some examples of why a free market health system will not produce good outcomes. We'll have lots of hospitals. You know, one of my professors, she's at Harvard, she told me, when you're going to a new country, don't ask anybody if this has a good health system or not. Simply walk out of the airport. If you see advertisements for hospitals, you know it's a bad health system. Because what you're seeing is excess supply, trying to bring in excess demand into the system. Countries that have bad health systems, like ours, have massive advertising. And what are they advertising? They're advertising the ambience, they're advertising it's like a hoteling type advertising that is going on, rather than the quality of care that is being provided. In such a situation, and this is an important takeaway, is that now if I transfer more tax to poor people, or if I have growth without a design around it, I will make situation much worse. Right? Why do we worry about, or why do we speak poorly about the American health system? Right? It's a terrific health system if you want to save a life. Right? It has all possible forms of medical capability. Right? So if you have the money and you have a life that must be saved, right? You go there. It will cost you. It will cost you an arm and a leg, but they will save it for you. Right? Why is it? Because they have massive supply of hospitals. There's virtually no primary care. Right? Because nobody is interested in that situation. Which tells you that there is something going on in healthcare that needs addressing at its root. You can't simply say, I will give more money to people, people will get richer, they will get better outcomes. Take a state like Kerala, for example. Much richer than Chhattisgarh. Much richer. If you look at their situation, and unfortunately Chhattisgarh in some dimensions doesn't compare very well with them, but Kerala is a system that we look at and we hold up as an example. It's an almost entirely free market system. If I look at delivery of babies, C-section rates, cesarean section rates have crossed 60, 65, 70%. Private sector is doing its own share, government is doing its own share. There are many districts in Kerala, Ernakulam being one of their central districts, where the government C-section rates exceed that of the private sector. It's a classic example of a free market system doing whatever it feels like doing. If you go to Kerala, primary care on the other hand, very nicely equipped. Unlike in many other states where primary care is empty, there's nobody there, tala laga hua hai. That's not the case in Kerala. There's a doctor there, nurse there. So what is unusual about Kerala? It's empty. There are no patients. One a week, one a month. The average from government data, and government data tends to be, overstate the numbers. So it's an upper bound of the actual patients they are seeing. Again, another example of this situation that you're seeing on the ground. What is going on with healthcare? What is the characteristics of healthcare that are producing this kind of failure? There are 4 that I've been able to identify. I'm an early stage researcher. This is stuff that I'm still learning about. One is clearly underinvestment in public goods. This is something that you are all aware of. Public goods are goods without which markets can't function. So for example, if you didn't have contract law, if you didn't have legal system, you didn't have the judiciary, you didn't have police, you can't run a market because nobody will honor their contract. You said, I'll buy something from you, you will pay something to me, right? But there is no legal system to protect you, nobody will honor the contract. It will become a jungle law on which nothing is going to happen. It's a classic public good that you need investment on. And there are many dimensions in which public goods are not being invested in adequately. And I will talk a little bit about, for example, we were having a discussion about newer cities being built in Raipur, Naya Raipur being a nearby example, right? One of the things we know are very important for cardiac health is pavements, not green spaces and parks. Nobody goes there. I live in Bangalore, beautiful parks, empty. Good for me, because if I want to take a jog, I don't run into people every time trying to avoid it. But a bad waste of city money. In fact, the evidence is pavements lead to better cardiovascular outcomes because people walk the 30 minutes a day that is needed naturally as a part of their routine activity rather than because they went to a park. In fact, even to play for kids, you might say parks are good for kids. Actually not. It turns out that in order to have kids benefit from the park, you need an adult to take them to the park. And adults often don't have time. In fact, the experiment that has worked much better are what they call play streets, which are safe streets, safe pavements where children can play if they can't play in their own building compounds. In fact, play is one area in which you get a curious phenomenon. The very poor get a lot of play, the very rich get a lot of play. The middle income who live in these housing colonies with cars parked everywhere, they don't get much play. Good design of cities is a public good. Naya Raipur has no pavements. I couldn't see any. Right? I worry about that city because if you grow cities like this, you will not get. It's a car design city. It's meant for cars. Right? Not necessarily. If you go to a Chinese city today, or if you go to central London today, right? They've introduced a congestion tax in the city because they recognize that walking is an important public good. So if you bring a car in, an automatic camera will take a photograph of your number plate, you'll get a bill at home for having come to the central district of London to pay a congestion tax. So underinvestment in public goods is a very, very important dimension of why healthcare systems fail. But most markets will fail. Other biases are unique to health systems. Information asymmetry, I don't know what is wrong with me. I'm hypertensive. I will not start fainting until my hypertension levels cross extreme. But it does not mean that if I have a moderate level of hypertension, my risk of stroke, my risk of a myocardial infarction, there is a heart attack are not growing. They are. Right? My risk of kidney failure, they are all growing because I'm not thinking about issues that are worrying about me. It's an information asymmetry problem. Sir mentioned examples of doctors and patients, right? There's clearly something going on with an unequal power balance. Unfortunately, one problem with healthcare, unlike in toothpaste, when you go to a supermarket to buy a toothpaste, you know what you want. When I go to a doctor, I don't know what is wrong with me. So I'm unable to value what the doctor is saying. If the doctor is telling me I need a C-section, I will say, "Bhai, doctor sahab, aap jo bolenge, hame kya malum?" Right? You can't tell me, no, sir. Actually, I read somewhere that my baby is positioned correctly for a normal delivery. And he will say, "Ki bhai, itna hi aapko malum hai, to hamare paas kyun aaye? Aap hi kariye." It's a classic problem of information asymmetry. Behavioral biases, clearly something that I'm sure you've looked at, much more a marketing, consumer type problem. I was sharing with your colleagues, one of the challenges of behavioral biases in healthcare is that actually evolution needed us to become not as risk averse as you might want us to be if you buy insurance. Right? Because otherwise you would not cross the street. And you needed a risk-taking attitude in order for the species to actually grow. But unfortunately, in today's world, that is hurting our ability to do stuff. Very high volatility expenditure, something I don't need to explain to you. Most days nothing happens. Suddenly you get news that घर में किसी को cancer है. And then now you're talking about a 25 lakh bill, right? Which is a shock that you have gotten. Fortunately, one of the issues about healthcare in India is that we are a massive lagger. It's not that we are a mildly behind. We are ranked 150th odd in the world, and there are countries like Rwanda, Ghana, Kenya that have raced ahead of us in terms of healthcare quality. That's a bad thing for sure, but the good thing about that is there's a lot we can learn from the examples of other countries. Clearly, underinvestment in public goods, there is a lot that can be done. Right? I have a paper on Chhattisgarh that I'm working on, that I'm trying to collaborate with your colleagues to actually take it forward. I list a number of areas. My own area of work in the Banyan is public mental health. I worry about not so much अगर आपको दिल की कोई बीमारी है, so what can we do with it? Right? I worry more about how can I strengthen your ability to not be mental. And you will be surprised to learn there's a lot that can be done, including in difficult areas like schizophrenia. Schizophrenia, it's a pretty severe disorder. If you look at the disability weight assigned to schizophrenia, it is assigned at a 70% disability weight. 100% is death. Right? Which means if you have active acute schizophrenia, you're only 30% alive in that waiting scheme. Right? So it's a pretty severe disorder. We know, however, that if you are part of a family in which there is a schizophrenic first order element, your chance of getting schizophrenia is 8 times higher than that of the general population. We also know that schizophrenia is a disease that onsets in adolescence. Somewhere between 14 to 18, most of the time is when you switch from being an at-risk person to being a schizophrenic. This knowledge can be put to good use to understand what are the triggers, often stresses. So guidance to families to not encounter high stress. Don't move your home, don't leave a job around this time in your child's life, for example. Think about what's going on in your child's mind before you take actions that have an impact on them. There are a number of other interventions but to think about, but clearly something that we could be worrying about in the public health. Information asymmetry is only, a lot of people will tell you, educate people. If only people were smarter and more educated. I tell them, if that was the case, you would have no obese doctors. Whereas if you actually meet lots of doctors, they're eating golgappe all the time. Many of them are sporting bellies that are more impressive than mine. And, many practicing many unhealthy behaviors. Information has a certain role to play. It is not actually the dominant. Again, going back to mental health. Right? If I look at bipolar disorder, the cure for it, unfortunately the mind and the brain we don't understand very well. A lot of the understanding we've gotten has come from empirical data. That is, we've looked at the evidence from what medicine does for us and then inferred backwards what it is that we are. Lithium is an important medicine that was discovered this year. Right? The story of lithium is a very legendary story. I don't know if you've had this drink 7-Up. Up in 7-Up was lithium for a long time. Right? It's a naturally occurring chemical in your body, so it's not as horrific as giving you morphine. But morphine occurs naturally in your body. But why was lithium so powerful and so important a drug? Right? Because it's a mood stabilizer. If you're too high, it brings your mood down. If you're too low, it brings your mood up. It was discovered actually by accident. The doctor working on schizophrenia in 1949, he was experimenting on guinea pigs to try and understand schizophrenia. To understand, basically to see what triggers schizophrenia. So he believed some chemical that you are secreting in your body that is causing schizophrenia. So he took urine samples from schizophrenics and non-schizophrenics and gave them to guinea pigs. And his family reports this because guinea pigs are nocturnal animals. So raat mein bahut shor machate. So they could not sleep well. Right? When he started his experiment, suddenly sleep was very nice. Guinea pigs stopped making noise. But both guinea pigs, inko urine mila schizophrenics ka, those that got urine of non-schizophrenics, both were quiet. It turns out that he was using lithium as a storage medium for urine to make crystals. That's what he was giving the guinea pigs. After a while he discovered it's not the urine but the lithium that is actually resulting in this benefit. Powerful drug. Yet a year later, bipolar patients, 50% non-adherence on lithium control. Partly because they miss the mania. What happens in bipolar disorder is, it's not the bad that people don't like. It's the good, because they feel they're the most productive, they're energetic, you're an army general, you're running, you feel like you're almighty. Suddenly with lithium, you don't feel that anymore, and you miss it. Whatever reason, you definitely see a lot of information asymmetry. The only answer is not information, but finding a structure that creates the relationship in which you outsource taking care of you to somebody else. Like some other partner that is actually responsible for it. Behavioral biases, again something that we have discussed earlier. Managed care is another important area. One of the things I was asking your colleagues was, what is the importance of corporate sector in Indian health? Right? Fortis, Apollo, all these big hospital chains that we think about. Right? And first instinct, even my first instinct before I looked at the data was 50-60% of the market must be them. Itna paisa kama rahe, itna log ko charge karte hain, kuch to market share hoga. It turns out that it's 4%. They are so small that if they vanish tomorrow, you wouldn't actually see a lot of difference. Maybe our lives healthcare will change because they may be our primary healthcare providers. But in the bulk of the population of the country, it wouldn't matter. Right? In fact, they are so small that a mid-sized US health system, Henry Ford, it serves a part of Detroit. It came out of the Ford Motor Company. It has a top line of about $6 billion. If you add up all the corporate sector top lines, it doesn't come to that number. So they are a really tiny space. Part of the problem is that they are trying to play in a space which is a very narrow space, which is tertiary care, which is 0.2% incidence. And then they need people who have enough money to pay for that. Insurance is just 7%. So bulk of the people they are expecting are the rich. Now, after Sir's discussion, you can imagine the proportion of people that can afford to go to a tertiary care hospital and pay that kind of money is a very tiny number, which is why they are not growing. Right? Managed care is an opportunity for them to try and see if they can build growth. And clearly it's something that we can think about. There are many ideas that we can work on towards bringing this kind of healthcare, and addressing this issue. I'll quickly go through some of the ideas that are, none of them are new ideas, none of them are ideas that, my original research has produced, but they are ideas that I think have power in our system. And, let me, instead of going through it for, all of the other states, let me just focus on Chhattisgarh to try and understand what is going on in Chhattisgarh and what can we do about it. Since we are here in Chhattisgarh, we are talking about growth. Chhattisgarh is doing, unfortunately, particularly poorly on virtually any dimension that we can think about. Right? There are three broad dimensions in which we evaluate health outcomes for a state. One is maternal child health, infectious disease. The second is NCDs. The third is injuries. Broadly speaking, suicide is the number that we are interested in. Road accidents is also another part of injuries, but we are interested in suicide. Unfortunately, Chhattisgarh has almost the worst rank on all three fronts. Now, what is the problem? Well, one of the challenges is at all levels, you're seeing a problem with the quality of healthcare being delivered. Primary care, if you talk about antenatal care, which is 4 simple visits, WHO has made it 8 visits now, 4 simple visits, only 20% of women are getting 4 simple visits. Now, this is 15-16 data. I don't have the 19-20 information analysis here, but this is the numbers. In fact, only 30% of women get any antenatal care from any government. Institutional deliveries, the state has done very well. From 70%, it has gone to 85%. And a lot of it is happening in the public sector, which is a remarkable credit to what the public sector is able to do. But 80% means 20% are not getting the institutional delivery that they do. And you see in many districts, Bijapur, Mungeli and Bastar, they remain 70% and they have fallen. And this is pre-COVID, from the 15-16 years. Clearly there is a challenge on the primary care front. But sir, the number, I don't have the 1920 data, you may well be right, but the number to look at very carefully is the same woman getting all 4. Right? My understanding is the number falls quite a bit, but 65%, but still not 100%. You know what I'm saying? There's a large gap. The other problem, you see this number, right? I spoke to you about Kerala, which is here, right? You can see, you can see Kerala is here, right? C-section rates are 35%. This 15-16 data. You see Telangana is here. 60% is the state average. There are districts with 90% C-section rate. Unfortunately, Chhattisgarh is here. So we have, unfortunately, there is a talk I gave in Bangalore on too much too soon and too little too late. We in Chhattisgarh are sitting with too little too late. Right? And, unfortunately, the data there is really quite bad. Right? If I look at the situation on C-section, 15% is the WHO norm of what is needed. Right? Only 8 of the 27 districts are beyond 15%. We don't even know if this is medically necessary numbers. This is just 15% C-sections. Right? There is a large group of women that will want elective C-sections. Right? What the British call too posh to push. That's the number that you might be seeing. There are states, there are districts, Sukma, Bijapur, Kodagaon, less than 5%. which means there is a large number of women that needed surgery. You couldn't give it. What happened to them? They died. There is no ambiguity about what happened to them. Right? Unfortunately, what happened to their children is much worse. I have been to a facility in Bihar, in which I was the head of Gates Foundation in India for several years. We had funded a sick and newborn care unit. It was full of babies. And I was thinking to myself, these babies look good. They are big babies. They are not the tiny babies. I had been to Amrita Institute in Cochin, and I saw a similar unit, but full of tiny little babies. On respirators, and pediatrician telling me, sir, this child will grow up to be an Einstein. Don't worry, he will do well. The pediatrician here is whispering to me on the side that he hopes the child dies and doesn't really, because the C-section was delayed enormously. The child has got asphyxiated and has lost all biology. It's just a body that is surviving, and the family is waiting eagerly outside कि कब बच्चा release होगा, माँ तो मर गई, बच्चा तो कम से कम रहा हमारे पास. Heart-rending. Unfortunately, this is because a lot of the necessary care is simply not available. We did a large trial in UP, in which we tested the idea that if we improved primary care, what would happen to child care? What would happen to maternal care? It turned out nothing. It didn't produce any beneficial outcomes for maternal mortality because, a lot of these norms were developed by organizations like WHO when mortality rates were much higher. Today, even the worst performer states in India have got mortality rates that need good medical capability to be available. This is not available. And unfortunately, this is another area where we have many more experts in the system that are here. This is old data. I'm told that the data new is looking much worse for Chhattisgarh. We are showing suicide mortality rates that are significantly high. Compare this with Kerala, for example. Compare this with Bihar, for example. Okay. We have income levels roughly here, but we have suicide mortality roughly here. It's clearly a significant problem. What is the situation? Low government spending. Chhattisgarh is spending roughly half what it needs to spend. Many will argue even much less. High disease burden on all fronts. And on top of that, a very challenging job. The 4 recommendations that, this is a research paper, mind you, not that the government asked me to make these recommendations. These are so moto, I'm making them, and this is a part of the discussion, the Lancet Commission. I chair the Lancet Commission's finance work stream, and this is part of that work that I'm doing. And hopefully there will be many interesting papers that will come out of this area. Clearly, public health has to receive focus. Right? Unfortunately, you're not seeing the kind of effort public health needs. I already mentioned to you roads. There are so many issues. I'll give you one little anecdote that I shared with your colleagues is on tuberculosis. In the near term, if you say what to do with tuberculosis, we are losing 1,000 people a day. Much more than COVID took from us. Right? We don't report it because it's not happening to us. It's happening to poor people somewhere in slums of Bombay or in the forests of Chhattisgarh. We're not worried. Clearly, we need to treat these people, no question. But if you talk about treatment as the only answer, you'll run into one difficulty. 40% of Indians have latent tuberculosis. 40% in this room may have latent tuberculosis. If you go abroad to get a Ph.D., they will ask you to take a tuberculosis test if you're an Indian. And many of us will be found positive. Right? You will get a treatment. It's not a scary thing to happen. You'll get some treatment and you'll be fine. Right? But you do have to. The key challenge for us is, if you want to prevent the crisis, how do you prevent latent TB from becoming active TB? What you find is that, because of the way building codes have been designed, I don't have time, but otherwise it's a lovely story. If you go to Bombay, I will want you to talk to me about that story, about how 2007, under the Slum Rehabilitation Act, we diluted a 100-year-old British law that prevented TB from turning from latent to active and created buildings that are deathbeds because they have no light, no air. Why does a city alter a building code? It has no value to the city. Right? It is something that a builder is going to benefit from. There was no logic. no logic to doing something like that. So clearly there is a public health issue. I am arguing, many people will disagree with me, improve settlement. There are many districts in Chhattisgarh today that have very little settlement. And there are a number of problems. I'm not going to argue to you, easy to do. But there are states, for example, Andhra Pradesh is a rural state, somewhat similar. Chhattisgarh is much harder, but somewhat similar to Chhattisgarh. Vacancy rates for specialists in rural districts in Andhra Pradesh, 3%. Vacancy rates of specialists in rural Bihar and UP in excess of 50%. I don't know the number for Chhattisgarh, but I bet you it is very high. Something we can learn from them. We are doing work separately in the Northeast on how to bring tele-ICU capability to remote rural areas. You might say, well, primary care ka kya kare? Well, it turns out the primary care situation is a little bit more complicated than we had imagined. It's not as if there is no primary care. It turns out 90% of Indian villages, including in Chhattisgarh, have actually adequate primary care. Who are the providers of primary care? Not government. Yes, indeed there are all kinds of providers, but a lot of them are pharmacies. We have 8 lakh pharmacies in India. In fact, our pharmacy density per lakh is one of the highest in the world. There's a very nice study for the district of Gyan that looks at this data, and you find, as they say, if you go to Netherlands, every second shop is a sports shop. You go to any city in India, every second shop is a dawai ka dukaan. Many countries have converted this into partners for mental health, for diabetes, because they know patients are going there. So clearly there are opportunities here in this. In the long run, we have to worry about public sector performance, not an issue for Chhattisgarh today, but a big issue for a state like Kerala, a big issue for a state like Delhi. Because one of my papers is arguing that these states are incurring an enormous amount of waste that needs attention from the government. And clearly government funding has to be improved. The reality of most countries, in fact, I could not find, I have a paper that looks at 200 countries. High-performing health systems, 75% plus, are funded by tax resources of the government. There's no getting away from it. You might say, I don't know Chhattisgarh well enough. Government may have many priorities that need attention from the government relative to healthcare. So I'm not going to say, therefore, I will sit and say Chhattisgarh should do this. At a national level, though, I can say that a lot of the expenditure of the government is going into areas where the government does not have a role in. Why are we building more roads, for example? India has more roads per square kilometer than any country in the world, except France. We are more than the US, more than China, more than any European country. Why do we need more roads? But every government is saying, road banana. And clearly there are concerns that we have about all these, star projects in which it is not clear who are they benefiting and why is government spending. I don't have any problem in which you build, super high-speed capabilities, but let the private sector pay for it. I've been a banker for 25 years. I headed, me and my colleague, we ran ICICI Bank. I was DMD, my other colleague was DMD. She ran retail, I ran wholesale. I was the project finance guy. There's no projects that in the country that we cannot fund. Right? The minimum that we did as ICICI was 5,000 crores plus. Right? So, why is somebody coming in and saying, I will do your work? But no, I'm ready. We are looking for business. Clearly, there are areas in which funding is going. It's not obvious government should be paying for it. That money should be coming here. As I said, Chhattisgarh is a unique situation, so I don't know enough about what they should be doing. I'll stop here. There are many slides that I still have, but I can see your colleagues are getting anxious. Their time is running out. And I'm keen to hear from you what you have to say if there is time. Thank you so much.
Thank you, sir, for sharing your opinions and experiences with us. The stage is now open for Q&A.
So my question is that, what do you think is the role of pharmaceutical companies in healthcare? Because we can see in India, they are charging very high prices, as well as they are not providing that much quality of their product as well, where in US there is FDA who has proper regulation guidelines. Here we don't really have any upper cap for medicines as well. And my second question is how we really nudge the people or the doctors to get into the public health system, because in NHS there is a high shortage of doctors and there is very high waiting list as well in UK. So what's the solution for that?
Good question. I mean, everybody has a story to tell. All I can tell you is I was on the board of CIPLA for a while, and we in CIPLA make the entire essential drug formulary, all the essential drugs. And prices you cannot imagine. They're very, very, very low. Anywhere in the world, you will not get drugs at these prices. So India is actually in a very advantageous position. Today we make 60% of world's vaccines. In fact, when India couldn't supply coronavirus vaccines to countries, disease burdens in those countries went up because they had no other choice. So on the pharma front, while I agree with you, there is the odd corruption scandal and we have a good drug regulator. I am not going to therefore excuse the whole issue that happened in the Gambia, but it's clearly an advantage for us. In fact, my argument is the opposite, which is we Indians have enough money to deliver universal healthcare to every single citizen, including the state of Chhattisgarh. If you're not doing it, in Hindi we have a saying, जो आदमी सोया हुआ नहीं है उसको जगा नहीं सकते. Right? We don't want it. Right? Clearly. Second issue of doctor shortages. See, somehow what has happened is, and this I saw this in, I was on the board of Wipro, when Wipro before it became the Wipro. We were known for Sabun, Chandrika, Santur, these were our, bulbs. We were not known as IT company. Why? There was a shortage of engineers. What did the country do? We hit the market with enormous supply, perhaps too much supply of engineers. Right? Those street make engineering college. Quality control gradually happened because if you couldn't place your students will stop coming. Right? This is a market that adjusts very, very quickly. It was one of the reasons why India became an IT superpower. Why can we not take the same view towards medical education? Not just that we are producing enough doctors for ourselves, to become exporters. You know who is the largest exporter of doctors in the world? The tiny country of Cuba. If you see Ebola, you will hear about, MSF, Doctors Without Borders. But actually, they are not the largest suppliers of doctors. It's Cuba. But because it's a country nobody wants to talk about, right, nobody mentions Cuba. Why can we not do that? Why can we not say, and if you read people like Dr. Devi Shetty, he has many good ideas as to how we can increase supply. I have a paper that I wrote in the request of the government on how the whole issue of fees can be taken care of. There is a whole strategy for funding medical education costs called income contingent lending, ICLs. Worldwide, people are moving to ICLs. What is that strategy? The strategy is if you get admission in a professional education, including an MBA like this, right? Professional education, doctor being one of them, your fees are automatically paid by the government. How do they recover it? From your tax returns. If your taxable income crosses a certain number, automatically 9% of that surplus is deducted until you've paid your loan off. If you work in the public sector, actually pays well. So don't assume the public sector pays badly. In fact, only in the super specialist category does the public sector pay less than the private sector. Nurses, public sector actually pays almost 2.5 times more than the private sector. MBBS doctors, I would imagine they are on par. But it's not as if it's a shortage of money. It's a difficult working environment. It is locational. There are other issues that are problematic in the public sector that may not be getting people. But if you hit the market with surpluses, there will be jobs everywhere. So, my view is, why do we, as Sir had said earlier, why think of a problem which is Malthusian? Oh my God, we have too many people, how will run out of food? Instead of saying, how can I improve the productivity of farms so that I never have that problem? I would take the latter view.
So I'm Arvind from Degree Batch 2024. So my question is, as you rightly mentioned, countries like Cuba, Denmark, Norway are able to provide healthcare services from the public sector to the citizens of the country for almost free. When in our country we know that there are government officials themselves, when they need a healthcare service, they go to private sector. How to change the disparity in our country? We are growing economy, we are developing, but how to change this state of our country?
The reality, unfortunately, know what I am getting into where. When we say government health system, right, while it is all paid for by the government, but if I ask a person who went from a government primary care center to a government hospital, was there any connection between the two? No. That was a separate encounter. This is a separate income. You will get a woman with extreme anemia, about to deliver a baby. She has been measured for anemia at the PHC, but the data is not anywhere. So we have to start delivery without knowing is this woman anemic or not. There's no system. There's no sense of what is going on. There are clearly challenges in the quality front. I'm not going to tell you now. But it's also an issue of perceived quality. If I don't know what is good healthcare, I don't know if I'm going to a fancy place which is charging me a lot of money, or am I going to a bad place, bad looking place, which I'm getting actually terrific healthcare. And oftentimes, why do politicians pay and make sure that they go to AIMS? The best doctors are in AIMS. They are not in a private hospital. Because the research mindset, the whole quality work, if you go to Arbinda, it's a bustling place. Because 60% of the patients are free. But if you're a rich person and you have a problem with your eye, where do you want to go? To a doctor that has seen 3 patients in his whole life? Or a doctor that is doing 20 surgeries a day? Naturally, you want to go to the latter. So, my sense is if we offer the system, let people opt out. Today, that system is not. If I'm a poor person in Chhattisgarh and I said, I need help care, God help me. Right? Because there really is not that much. You know, and if I happen to live in Bastar, whoa, I'm in a really bad shape.
Thank you, sir.
Two, 3 points. One is that Chhattisgarh is also moving towards universal healthcare very soon. We are doing good in Ayushman Bharat, providing claims and all, but very soon there will be cashless counters. We are moving towards that. Free drugs, free no registration fee, free diagnostics. So we are moving towards that. And as far as other indicators is concerned, so in you're saying that cesarean section deliveries are an indicator. Yes, we have now 18% of the deliveries as cesarean deliveries in Chhattisgarh. There are few districts which are not doing so good, less than 5, in Bastar area only, very small districts population-wise. But overall, there are districts like Raipur which are having around 49% deliveries as cesarean deliveries. So, no hospital should have more than 35% deliveries as cesarean. That is also criteria. So, 15% is the norm, as you say, should be there. After that, then it's profit making and all that. So, we are slowly moving towards that. And in the last 3-4 years, we have recruited a lot of doctors. Now, there are hardly any vacancies in MBBS level. Specialists, yes, there is a problem. And we are trying to get that. But A&Ms, everywhere there are A&Ms in several centers. Immunization rates are quite high now. And delivery, as you have told, more than 85% of deliveries, as per the NFHS 5, which is recently released, is good. Immunization is also good. ANC and all is around 65% as per the NFHS, though actually they tell it is more, but we believe NFHS is a very fairly trusted survey. And so we are trying to improve, and we have our health and wellness centers now. We have got CHOs in 4,000 health and wellness centers, which are recruited through NHM. So I think very soon, all the sub-health centers will have one additional CHO in addition to already A&Ms which are having. So I think we are trying to, HR is an issue in Chhattisgarh, and we are trying to cope up with it.
My request to you, sir, is you have a wonderful institution right here.
Yeah.
If you can collaborate with them,
Yeah, we would like to.
That would be terrific, because there are many problems that,
Yeah, we will collaborate with you.
There may be other problems that, like HR, you are saying, and I'm sure there are many eager faculty here that would love to collaborate with you and to get in and see if they can help solve the problem. And they are based right here. And it would be wonderful to have an opportunity to collaborate.
Sure. Thank you.
So my question is, like you said, to improve healthcare in our country, we need a lot of money. So, like, assuming that we can get the money from the government sector or the private sector, so, like, if we take money from the private sector, eventually, like, it needs to make a profit, right? So, it needs to recover that money. So, that's one thing. And if we take money from the government sector, it needs to come from taxes. But in India, only less than 5% of the population pays income taxes. So, like, is there an actual solution, or are we in a catch-22 situation right now?
No, it's a great question. Percent tax GDP ratio. This is the same as Thailand. In fact, the country that has a terrific health system, Iran, has a tax GDP of 7%, including their oil revenue. What those governments have done, have decided, for example, we spend 5% of our budget. If you take any state budget, 5% is allocated to it. Thailand, the number is 50%. Because government has withdrawn from many services or many activities that they think the private sector can do. In our markets, as I argued earlier, our government is very engaged in business activities. Banking, insurance, airline, chutti. You know, there are many businesses in which the government has no role. But it continues to allocate money for it. And as a result, we have no money left, not enough money left for it. Also, you don't need a lot of money. One of my papers, and hopefully it will go through the publication, then I can say it with more confidence, is suggesting that about 2,000 rupees per capita is all we really need. Deliver universal healthcare. There are 13 states in India, Delhi, Goa, Kerala, Himachal, all of Northeast except Assam. They are already spending more money than that. Why are they not delivering UHC? Because, as I mentioned earlier, Kerala, for example, has C-section rates in the government hospitals that exceed that of the private sector. But in primary care, there is virtually nobody there. The good thing about India is, for example, let's take HR, significant problem. But that is because we are obsessed with doctors. If I look at the Alaskan health system or the Iranian health system, Iranians have a health worker called the Behrwas, comparable to our Asha. Our Asha is very literate, is able to do a few things and paid on contract, not even paid a full salary. Right? The Behrwas is a full-fledged medical person dealing with mental health issues, dealing with NCDs, dealing with a broad set of conditions. Why can't we do that? Today we have technology capability that even the Americans would envy. But you go to any hospital today, public or private, no data is being captured by anybody except in you're carrying big fat files around with all your data. If you're carrying those big fat files around, who knows what is your life history? We know, for example, that if you're assessing somebody for breast cancer, I have to have data about when did you have your first child, when did you have your first menses, what is your aunt's breast cancer situation. ये data कहाँ पर है? डॉक्टर तो तब की तब पूछेगा नहीं, इस सिस्टम में रहना चाहिए, वो है नहीं. So we are in a little bit of a situation of not so much catch-22, but what I said earlier. We are not asleep, but we refuse to wake up. And I feel the opportunity, which is one of the reasons I came here, institutions like yours, particularly the faculty members here, you're sitting right here in Raipur, right next to NARAD. Your ability to do research, to do high quality thinking, collaborate with the government, and give them ideas, give them solutions. Government will also have to change. Government today takes the view that they are a competitor of everything. This is unique in the healthcare system. That's not true in banking, that's not true in many other fields. But the government thinks of itself as a complement. Today, as I mentioned earlier, bulk of healthcare is happening in the pharmacy. सबसे महत्वपूर्ण प्राइमरी केयर डॉक्टर है दवाई के दुकान वाला. Now, one view is, अरे सब चोर है, बंद करो इनको. Other alternative, 40 countries have done this. Rich countries like Portugal, mid-income countries like South Africa have said, नहीं, आप वहीं जा रहे हैं, why don't we collaborate with you and train you to follow some protocols and give you an intermediate certificate, like we are given to IIM, like we are given to Asha, to you as well. I believe it can be done. And what Sir was saying, already good progress has been made. Now, if we put our minds to it, I don't see that as a 20-year project. What I worry about though is the social determinants, the issues that are around us. Why is mental health becoming a bigger and bigger problem? It's not because we don't have psychiatrists. Right, we don't have, that's a problem. We have only 10,000 psychiatrists for such a large country. But that's only part of the problem. Part of the problem is we are not addressing public mental health concerns. We are not strengthening the ability. Police constables, they are one of the most stressed communities. You can see why, you know why. In the entire police force. What kind of mental health prevention work happens with constables? My understanding from talking to the police, none. None. These are opportunities for us. Free goods, doesn't cost money. Right? Good tested ideas that we can work with, that the armies around the world have perfected. I think it's global. You will hear from people कि नहीं पैसा नहीं है. अरुणाचल भी 10,000 रुपये स्पेंड करता है पर कैपिटा, बोलता है पैसा नहीं है. केरल 2,500 करता है, वो भी बोलता है पैसा नहीं है. बिहार 500 रुपये करता है, वो भी बोलता है पैसा नहीं है. Somewhere there has to be enough money. Sir is saying there are 1,300 rupees. We are doing very good work. Now, I like to hear that. Because अगर 1,300 में आप कर रहे हैं, 2,000 में तो आप कितना तीर मार रहे हैं? Right? Which is roughly what I think is the money needed for delivering full UHC to the entire population. Thank you all for listening to me so patiently.
Experiences with us and inspiring us this evening. On behalf of IIM Raipur and Chhattisgarh State, I now request Shri Abhijit Singh, IAS Managing Director of Chhattisgarh Medical Services Corporation Limited, to please come on stage and present our guest with a token of appreciation. As we come to the close of this wonderful evening, I invite Professor Ashapurna Barua to deliver a vote of thanks. Ma'am, please.
I would like to express our institution's sincere gratitude to our esteemed speakers, Shri Tulsi Tawadi and Dr. Nachiket Mor, for their talk. It was insightful and a delight to listen to you. Thank you. My thanks to the guests of the evening who have graced the occasion with their presence. To make this third Gyan Varsha intellectual series a success, we have a group of people putting in their continuous effort and time. To start with, I extend my gratitude to our Director, Professor Ramkumar Kakani, our Dean, Professor Kamal K. Jain, for deliberating on such a novel idea and facilitating the execution of it. I have to mention here Dr. Ketu and Vivek for all the hard work they put into planning the event and the seamless conduct. My thanks to the other members of the Gyan Varsha committee, Dr. Arunima and Dr. Munal, for their contribution and effort. We always owe it to the IT department and our administration to make the event of this scale happen. Thank you. Thanks are due to the students of Provokta for their unwavering support. Now, thanks to each one of you for your participation and presence in today's events, my faculty colleagues and dear students. So, this is a closure to our third Gyan Varsha, the Rockstars of India. We look forward to your participation in the fourth Gyan Varsha lecture series that will commence on 2nd of January 2023. Kindly save the date and pass the word. Thank you. Have a good evening.